So my name is George Beckmesian. I am just an average citizen, really passionate about understanding how the COVID response in this nation, maybe even throughout the world, how that has been affecting people. In particular, I'm interested about how a medical doctor here in Utah who has been experiencing the effect of COVID on patients himself and through his practice, right? And that's kind of what I wanted to start by talking about. So this is Dr. Ogden. I want to go ahead and ask you to introduce yourself, and so we all understand who you are and what your credentials are.
Okay. All right. My name is Jeffrey Ogden. I'm a general internal medicine physician. I've been in practice about 28 years here in Orem, Utah. My practice is Achieve Health. And I am a classically trained physician, MD. I graduated from USC Medical School back in 1990 and did my residency in internal medicine at St. Mary's Medical Center in Long Beach, California. After that, I came to Utah to practice initially as an employee of Intermountain Healthcare, and after a couple of years went independent and have been independent ever since. So my focus in my practice is on health and wellness. We deal with a lot with diabetic patients, hypertensive patients. Typically, the over 50 crowd is a large portion of our patients. So, you know, what I see is a lot of my patients have been affected by the current COVID crisis. So a lot of my patients fall into the high risk category. They either have multiple comorbid conditions such as diabetes, high blood pressure, cholesterol problems, obesity, respiratory problems like COPD, etc. Or they're elderly. So you know, over 65, 75, 85 even. People who have been needing to then stay inside, stay away from a lot of people. As a physician these last couple of months, then of course that means that much of the ongoing typical what we would say standard of care has had to be dismissed because we couldn't be doing face-to-face visits with people. We weren't able to initially monitor blood tests and such for congestive heart failure, like kidney function and that, the blood sugars. That typically we do periodic testing of things like hemoglobin A1C for diabetes management. So we weren't able to do that initially. You know, so yeah, I think that number one, a lot of people have had to set aside usual customary care, appropriate care for their chronic diseases, chronic illnesses during the course of this. And that's been a concern for me because I expect that a lot of people have kind of gotten out of control with things, maybe not been doing as well with their blood sugars, a lot of access to food, staying at home. People are talking about the COVID-15, those dreaded 15 pounds that people are putting on when they've been in social isolation. Anyhow, that's kind of where I'm at initially.
You and I met at the event in Vineyard where there was a business revival, and you were out there with a medical bus or a medical van, and so sounds like you're kind of a creative entrepreneurial practitioner, and you maybe were taking your practice to people who couldn't get to your facilities. Is that accurate?
So we started end of December with our patient transport van, and the intent was to be able to go out and pick up people who were having a hard time driving, or whose family members always had to bring them into the office, especially our elderly patients. And then the secondary thought was that when we have snow days and people are hesitant to drive in the snow, we'd be able to go out and pick them up. Well, we found that with the COVID and people staying at home, not wanting to be outside, we've been able to then, like I said, initially we felt like we couldn't provide appropriate care. And so what we've been doing is we've been going out and we've been doing checking vital signs and drawing blood on patients' doorsteps. So we come masked and with gloves, and we provide the patients with masks that they can use outside their home or when people come to visit them. And at that time, we check their blood pressure and such and make sure that things are going well. We've been out doing that once or twice a week, making rounds to people who are in need that way. We also took the time where we didn't want to send our staff home just because we didn't have a whole lot of patients in the office. And so we've been on the phone calling everyone. We're calling them, asking them, you know, are your physical needs being met? Do you have toilet paper? Do you have bottled water? Do you have someone going out and shopping for you, bringing in your groceries? We've actually gone out and gotten a few things for some patients and brought them to them. We've been able to actually provide things like hand sanitizer and such to people. And so yes, at the Vineyard event on May 2nd, we were there with our van and handing out face masks that people could use, you know, as they're going about in the community, along with hand sanitizer and such. Wanted to make sure that people had the opportunity to be as safe as they felt they needed to be, to utilize whatever barrier means that they felt was appropriate. But where people have had a hard time getting personal protective equipment, PPE, like face masks, we wanted to make sure that we were sharing with the community what we have.
I think that is really neat to watch how you and your practice have kind of, you know, evolved with what the circumstances have left you with. And so I think that it's important to understand that that Dr. Ogden, you don't think that coronavirus is not real, or there's not any concern, there's not people dying, like any of those kind of things. You're not some kind of conspiracist about.
I'm not a virus denier. Heavens no. Coronavirus is not a nice thing. It is killing people. There's no question about that. But I think that sometimes we get into a panic mode, and we misinterpret the numbers that are being told to us. And I do believe that the media in general takes the numbers at face value and doesn't understand or doesn't wish to interpret them as the CDC is putting them out there to be interpreted. And so we can actually kind of look at that if you'd like to take a look there. Let's see if I can share my browser out with you. Okay, so this is the CDC website up in the upper left corner. This is the CDC website. So this is May 21st, 2020. This data was updated. So as you can see, we have a total number of cases of 1,551,095. And that is all new COVID, or excuse me, not COVID, but SARS-CoV-2 virus positive cases. And then we have this other number called total deaths, and that says 93,061. This number, the 1.5 million people, are the total number of positive nasal swab tests for viral DNA. So that says that there is virus present in that person, that individual. So 1.5 million times we have done tests that have come out positive. And this is all since the onset of the epidemic, which officially for the CDC is February 1st.
So what else can we learn from these numbers?
Well, so we see total deaths is 93,061. And the important thing to note here is this does not say total deaths due to the SARS virus. It doesn't say total deaths due to COVID-19. Now, one of the terminology concepts that people kind of misunderstand is that there is a virus that's called the SARS-CoV-2 virus, and it causes an infection. And that infection is a respiratory infection, and it's called COVID-19. What does COVID-19 stand for? It stands for Coronavirus Infectious Disease 2019. That's why there's COVID-19. I've heard people say, "Oh, did you hear about COVID-20 and COVID-21? They're worse than COVID-19." Well, you can't have a COVID-20 or 21 because we aren't there yet. Definitely not a COVID-21, but there's COVID-19, and that's the disease that is caused by the SARS-CoV-2 virus. And COVID-19 causes an overwhelming respiratory infection with pneumonia that, like we all know, requires often a ventilator to help get you through that. And we have a significant number of people that do die from COVID-19, the disease caused by SARS, the SARS-CoV-2 virus. So understanding that, we look at this data, and this says total deaths, 93,000, but it doesn't say total deaths due to the SARS virus. It says here, this link about the data. Well, what does the data mean? And you can scroll down to the bottom here, and it tells you exactly what that means. It says all around the United States, and it says changes in how we define this go back to this interim COVID-19 position statement. And you can click to read that position statement. But basically what that says is that as of April 5th, every person in the country that dies from pneumonia, whether or not it has been determined that they had SARS virus present, we are going to count as a COVID-19, so the disease caused by SARS virus, even if we don't know that that's what it was. Now, if you remember back in April 5th, we didn't have significant testing going on. We were test deficient. And so that was probably an okay thing to do at that moment to try and get a grip on what was going on and how many people were dying. But we know now at this point that 90+% of people who have died under suspicious or presumed COVID-19 circumstances have been tested posthumously. So after death, they've been tested. And so we really know right now how many people died with the virus and because of the virus. So since April 5th, the CDC has counted everyone who died from pneumonia as if they were COVID, unless they had been documented to have influenza virus. Now, that's what it says down here. It says you had to meet the clinical criteria, so you had to have significant overwhelming respiratory infection and epidemiological evidence. You had to meet presumptive laboratory evidence or other clinical criteria, so you didn't even have to have a positive test or have been tested at all. But then here's the clincher: meeting vital records criteria with no confirmatory laboratory testing performed. Now, at the time, back on April 5th, we were way behind in testing, like I said. And so they made this administrative decision to treat every pneumonia death that wasn't defined as influenza as if it were COVID. But again, at this point, we now know, so we really shouldn't rely on that as the definitive determinant. And so
are those the only causes of pneumonia?
let's look at that. Let's look. So let's go cases, data, and surveillance. We're going to click on over here, and we're going to scroll down to mortality reporting. This is all, again, the CDC website. So daily updates of totals by week and state, and this is provisional death counts. Now realize that this is death certificate data, so it always lags about a week behind the actual minute-to-minute numbers. So these numbers aren't exact for today to the minute, but they are what has been reported and recorded on death certificates. So number one, we can see this column right here, which has 31,388 people. And this is deaths with pneumonia and COVID-19. So this says either presence of or presumptive presence of virus and pneumonia. So that's how we know that people with COVID-19 die. So we have this number that says 31,388. So that is the true people who have died from pneumonia due to SARS-CoV-2 virus. Well, if that's deaths with pneumonia and COVID-19, and then there's influenza deaths next to it, then what's this over here that says COVID-19 deaths? These are people who died after having tested positive with the SARS-CoV-2 virus, but didn't die because of a respiratory infection. So you can see there are 40,000 more people that died with the presence of the SARS virus than died because of the SARS virus. And so it's interesting that this is a column that's called COVID-19, but it's not the right explanation for that. So for example, if we take the most absurd kind of a case, if a young man goes out and gets tested for the virus and tests positive, and then decides to go on spring break and spreads it to 100 or 200 other kids out on spring break, and he goes surfing and he gets eaten by a great white shark and is killed, well, what did he die from? Well, accordingly, he is listed in this column of someone who had tested positive for the virus, but then went ahead and died of something else. So he becomes a COVID death. Now, interestingly, right next to him, we've got this column of 917,000, or near 1 million Americans that have died since February 1st, in this time period, February 1st to May 16th. We've lost 917,000 Americans to whatever cause. Old age, kidney failure, heart disease, car accidents, lung cancer, whatever. Almost 1 million people. Now, if we're in the middle of an epidemic, a pandemic that is killing excessive numbers of people, then this number of 917,000 might be bigger than expected, except in this column next to us, we have percent of expected deaths. And we are right at the median, the middle, the average for how many people we expect to have died in this time period. And that's 102%. But if you look down here each week, we had a big surge, and this was Easter weekend. Did our president not explain to us, and Dr. Fauci not explain to us, that around Easter weekend we would have the biggest surge and then drop off? And look how it's been dropping off, from 133% down to 84% now. But overall, we're at 102%. So there's not a big excessive number of people who are dying. So we've got 40,000 people who died with SARS virus presence, but not of pneumonia, not of the respiratory infection. So now that takes us up to 71,000, and we're going to flip back to the other web page, and we're going to look at it. How many people does the CDC say on this first page? 93,000 deaths. So let's look. We've been taking all of the deaths that were pneumonia, so this column right here, pneumonia deaths that were not influenza deaths, and adding them into the COVID pneumonia deaths since April 5th. How many people is that? Well, you've got 11,000 minus 6,000, so you got 5,000 there. 10 minus 6, another 4, that's 9,000. Another 3,000, there's 12. 15, 16, 17, 18,000 or so people. You add that 18,000 or so people to that 71,000 number up there, what do you get? It just happens to be around 90,000 deaths. And again, this provisional death count, these are death certificates, and they always lag about a week or so behind the actual data that's being reported up here. So you can see how the CDC arrives at these numbers, because of course they're looking at defined by vital records criteria, and that's when they decided April 5th forward they would count pneumonias not due to influenza as if they were COVID. Now let's look at one other criteria here, because what we understand worldwide is that and you've heard this statistic thrown at us 100 times, of the total cases, 90% of people never require hospitalization, right? You've heard that over and over and over again.
Yeah.
So that means out of this 1.5 million total cases, we would expect that there would be about 155,000, about 10%, 155,000 hospital admissions. Well, how many hospital admissions have there truly been? Let's look at that. We can find that on the CDC website, hospitalization rates and demographics. Let's click over here. They've moved it several times. It used to be one click to find it. Okay, and then we're going to sort by overall. And I don't know if you can read that, but it says year 2020, week ending May 9th. So this is a week lag. MMWR week, that's morbidity and mortality weekly report 19. And overall, 60.5 hospitalizations per 100,000 population. Now we have a population of about 330 million people. So that means there are 3,300 times 100,000 population groups. So we multiply that 60.5 overall per 100,000 times 3,300, and well, let's do that. Do you see the calculator pop up on my screen there? 3300 times 60.5. So the calculator, when I calculate that out, it comes out to 199,650 hospitalizations. So just about 200,000 hospitalizations. And that's a little bit more than we would expect from this straight 10% number that they keep throwing at us. But that's in reason, that's pretty close to that 155,000. We've got 199,000. So about 200,000 hospitalizations. Well, so of people who are hospitalized, how many people do we expect should be dying? Well, if we take this number and we say 200,000 hospitalizations and 93,000 people have died, that means nearly 50% of everybody who goes into the hospital, half of people who go into the hospital are dying? Well, that's ludicrous. You see, overall, in Italy, and that was the worst case scenario, in Italy, we had about a 30% hospitalized patient death rate. And that was terrible. That was tragic. That was horrible. In New York City, during its 2 weeks' time that there was a crisis, we had an average of 21% of hospitalized patients died, and that was terrible. The national average right now is sitting at 13%. So of patients who are hospitalized, including the New York episodes, of patients who are hospitalized with COVID, about 13% of people are dying. The stated statistics are about 40% will require ICU beds, and about 30% of those in the ICU are dying. So 13% of 200,000 hospitalizations, remember this 60.5 times 3,300, 13% of 200,000 is more like 26,000 deaths. It's certainly not 93,000 deaths. And that 26,000 comes pretty close to that 31,388. Those are similar numbers, not exact, because of course the data lags in one table and the other, but much more similar than this 93,000. So we can see where the CDC comes up with 93,000, but we also understand that all of the other numbers that we're talking about, this 33,000 to hospitalization rate, to the 12 or 13% death rate per hospitalizations, is internally consistent. It is much more in line with what is really happening, and so the root data is there. This is not a fake number, it's not a lie, but it's not what most people think it means when they look at this website. They think that the 93,000 being reported here means these 31,000 that are there. And when we think that it's 93,000, not 31,000, we think of that half the patients admitted to the hospital are dying, that instills panic. And that's what I want to help people understand, is that it's not as bad as they think. Now, is SARS virus a bad thing? Heavens, yes. It's killing a lot of people, 31,000 people. My understanding is that in the flu season this year, we lost 47,000 people. So that's more than the 31,000. But there were millions of people who tested positive with flu. 260 or so thousand hospitalizations with flu. We've only had 200,000 hospitalizations with COVID, and we've already lost 30,000 people. All right, so it's not a good thing. It's a bad thing, okay? Not saying it's not there. It's real, but it's not the 93,000 that people think it is. One other consideration, let's compare this to other pandemics. For those of us who were adults back in 2009, we were taught by our president, then Obama, to cough into our elbows. And with that, we were supposed to cough into our elbows because of swine flu, which was sweeping across the country and swept across the world. In that 4-month period that the swine flu epidemic was taking place, we had 60 million Americans test positive. Not 1.5 million, but 60 million Americans test positive for swine flu. We had 275,000 hospitalizations with swine flu. Still many more hospitalized than have been hospitalized with COVID. But we only had 18,000 deaths, and we've already had 31,000 deaths. So is COVID more lethal? Yes. Does it affect as many people? No. And I'll leave that to you to determine why you think that is, but I'm just pointing out the numbers. Swine flu, we didn't do any lockdowns. We didn't shut down the economy. We didn't close all the grocery stores. We ran around and did whatever we wanted to do. And we had 60 million people test positive and 18,000 people die. We've done a whole lot of shutdown. Still people are dying. We've had almost a million people die in this time period, but we've had 31,000 die of COVID. So those are the numbers. And hopefully that gives you a little degree of peace to know it's not approaching 100,000 people. Will it approach 100,000 people? My personal philosophy, my personal belief is that no, it's really not going to get anywhere near this total number of people. That I believe at some point, the true number will become the most reported number again. And I believe, as with coronaviruses in general, remember about 50% of common colds are caused by coronaviruses. This is a coronavirus. It will likely become endemic, part of our normal colds and flus each year. As we gain more and more people with antibodies to the SARS-CoV-2 virus variety of a coronavirus, then it will propagate slowly through the population, just like influenza propagates slowly through the population. So the difference, why were we trying to, quote, flatten the curve? We know that influenza propagates at about a 15% rate. So if a person infected with influenza coughs in the face of 100 people, 15 people will walk out of that room infected with influenza. We've known ever since January that the SARS-CoV-2 virus has about a 60% propagation rate. So if you cough on the faces of 100 people, 6 you're going to walk out with an infection. When we have greater and greater, quote, herd immunity, when we have 50 and 60% of the population that's already been exposed, then we're going to get back down to flu-like propagation, so a 15% or so propagation. And then it won't be a big epidemic, it will be endemic. It will just happen slowly, and we won't notice big surges and such in population affected. And hopefully we can achieve that before next fall, when it's likely going to come back again with all of the other coronaviruses. Anyhow, that's my take on the numbers. I hope that clarifies some.
You hear a lot in the news, you hear a lot of people saying that, well, we don't know if you can get this virus twice in a short period of time. And you just made the comment that the antibodies would reduce the propagation rate. How do you know that? And how do we know what's true?
How do you know when you hear a bark, how do you know it's a dog? Because it barked. So an animal with 4 legs and a tail that barks is a dog. If it meows, it's a cat. If it neighs, it's a horse. This is a coronavirus. It is structurally the same as all other coronaviruses that we have heretofore seen. It has different antigen presentations, and that's what we're talking about. You see those little spiky things on the pictures of the virus, right? Over here. Yeah, there's the picture. So the red things that are spiking out on top of this coronavirus are the different antigens. And the antigens is how our antibodies, our immune system, recognizes a foreign object. And so a coronavirus has a variety of antigens it can express. And these are the little grippers. Imagine Velcro in your brain. This is the Velcro layer. And that's how it attaches to our cells and comes into the cells and becomes an infection in each of the cells. So our body recognizes a variety of these antigens and becomes immune to them. We send out immune globulins, which then attack the virus and kill it. But if it's an antigen that we haven't seen before, a mutation of an antigen that we haven't seen before, then we don't have an immune memory. We can't react to it and fight it off and have it be gone in 2 to 4 days like a common cold. So we know that with all other coronaviruses, we build immunities after we're exposed to them. And those immunities can last for several years. Why do you get a cold every year? It's not because your immunity has waned. It's because the coronavirus or the rhinovirus has mutated a little bit and the antigens are no longer recognized. So there can be many different antigens expressed on the surface of the virus, different types of Velcro hooks. And some of those Velcro hooks you're immune to, and some of those Velcro hooks you aren't. And if there are more that you aren't, you're going to get a really, really bad cold or even a horrible pneumonia and get put on a ventilator and die. If you do not have any immune system that knows how to attack that virus. So the more people that develop immunity, we expect this will be just like any other coronavirus. Can we say with 100% scientific evidential proof that there will be long-lasting immunity to this virus? No, because it takes 2 or 3 years of doing longitudinal data studies to prove that. So no scientist is going to say 100% proven that we will have long-term immunities. But we do know now, we've had 2 studies. We had an Italian study done with patients that had been treated in the ICU and recovered that were not able to contract the virus again. And now we have a recent study just done at Harvard, yet to be published, involving, I believe it was 25 rhesus monkeys that were inoculated with the virus that developed IgG antibodies upon recovery and are now immune to the virus. Rhesus monkeys are commonly used to study viral response and correlate to the human population. So we expect that this is behaving just like all other coronaviruses and that we will obtain some long-lasting immunity. Now, whether that's going to be 1 year, 6 months, or 20 years has yet to be determined by the ongoing studies. But the expectation is that if you have IgG antibodies to this SARS-CoV-2 virus, that while you have those IgG antibodies, you should be you should not be able to contract the virus again.
Thanks for that. I'm going to change the subject a little bit.
We hear a lot of talk about like, we can't reopen things until we have treatment or until we have a vaccine. And there's even talk that we might have a vaccine by the end of the year. Now, realistically, to have a vaccine, to wait for a vaccine to completely open up, what are your opinions on that?
Well, you know, I'm certainly not a qualified vaccine specialist. I do not know of any vaccine to any viral or bacterial infectious source that that has been produced in 6 months' time. I know that the polio virus vaccine took, you know, what, 5, 7, 8 years or so to produce, and we went through a couple of years of testing before that was, you know, able to show definitive immune response. So that would be wonderful. That would be great. I think it would be a near technological miracle to have a vaccine coming around by this fall. You know, so I'm not expecting that personally. I don't think that a vaccine is required in order to resume normal activity. Something on the order of 60 to 70% of people who have died from COVID-19 are over the ages of 65 with other comorbid conditions. So we know that there are people who are more susceptible. When I last consulted that table that I'm not seeing right off the bat here, about a week or so ago, there were less than 100 people under age 25 that had died with the COVID. So this might be, we've got 0 to 25 is the blue line that's down here, 24 people. And this is the period of time you can see February 1st through May 16th. So that's the whole epidemic time. So we've got very, very low numbers. That bottom blue line is under 25 years of age. The purple line just above it is 25 to 34 years of age. Certainly a very small representation of that population age group. But you can see the 55 to 64 is this dark pink line here. And then all these others, 85-year-olds represent a huge portion of the people, the 85 years and older, that were dying here. If you just look at that one point, week ending April 18th, 85 years and older was 4,960 deaths that they attributed there. In the 75 to 84, you've got another 4,000. Well, that's almost 9,000 people there. 65 to 74, another 3,000. So you've got 12,000 people, 65 and older, and you only have another 2,500 that are under 65. So you can see those kind of ratios. So there are people that need to be protected, and you know, infectious disease is a problem. Respiratory infections kill our elderly loved ones. During this time, I have been very protective of my 81 and 85-year-old in-laws. I have gone shopping for them. We bring them meals. They have someone who helps them around the house. We've kept them at home. We've masked up visitors who came in to visit them because I want to keep them secure. I have not been one to put on a mask myself. I feel like I'm quite healthy and fit, and I don't have any underlying comorbidities that would put me at high risk. And so my belief for myself, and this is just my personal belief, was that if I am exposed to this virus, that would be appropriate. That's what humanity does. and I would hopefully recover and be endowed then with long-lasting immunity against this, so that I can go about my business taking care of people and not worry about transmitting the infection to them. So far, I don't believe I've had well, I know I haven't been sick. Let's just say that since that February 1st date. There's been a lot of anecdotal reports across the country of thousands and thousands of people who had a COVID-like respiratory infection that hung on for a couple of weeks, that tested negative for influenza. We had about 20 to 30 patients during the late January, early February time period who had prolonged coughs, fever, but were negative for influenza. And that's when COVID in the United States was kind of under the radar. So we weren't even testing for it at that point. So one might wonder, do we already have a significant amount of the population that has been exposed that has antibodies? Well, that's what we're going to find out. We will be doing more antibody testing. And the role for antibody testing is not to say, gee, I have carte blanche, I can go do whatever I want because I have antibodies. The role for antibody testing is to say that there are going to be certain people who have a much greater ability to interact openly in public with less fear. The more people that truly have antibodies to SARS, the less fear the rest of the population, the at-risk population, should have of having an infection being propagated to them. So for instance, we would like to see companies identify people who have high antibody titers as potentially immune, but they're definitely going to be unable to propagate the virus to someone else, and then allow those people to be interacting with individuals, clients, whatever, that might be at higher risk. So for instance, think about like a home health agency. They're generally dealing with elderly people who are at high risk. And if you can have that home health agency certify that, gee, you know, we've got most of our nursing staff have antibodies, they are not going to propagate the virus to these elderly patients, I think that would be a really safe opening. If you could be a restaurateur and have your serving staff be documented as being, at least for the time being, in an immune status, well, then that provides a degree of comfort to your patrons. And so I think that's kind of the role, the commercial role for antibody testing. Of course, what we really want to find out is we want to know underlying, do we have 40 to 50% of the population at large that has a degree of immunity to the SARS virus, because that's what will provide us with herd immunity this upcoming cold and flu season.
If this is a novel virus, then why is the rate of people infected at 50% instead of 100%?
That's a very good question, and you would expect that if this was truly novel, if it was an absolutely new virus with new antigens all over that virus particle, like we showed, if it had new antigens completely over it, that it would propagate 100% of the time. You know, just like they show in all the terrible movies, right? You know, Contagion or what have you. That it would propagate 100% of people, no matter how you got exposed to it. And this has not been that way. It has only been about a 60% propagation. And so I think a lot of us are wondering, you know, when that real first wave came through, or are there significant antigens on the surface of this virus that we have some immunity against, just not the majority of the antigens. And so are there people that have a partial immune memory to this already? So let's just make up a number. Let's say that on the surface of this virus there are 5 antigens, and I'm not saying that's what there are. I'm just going to say that for sake of conversation. let's say there are 5 different antigens. We'll call them A, B, C, D, E. And so last year, when we had coronaviruses come through with colds, maybe there was an ABC antigen on there, but not a D and an E. And this year we've got A, B, C, D, and E that are hitting us. And so that D and E kind of lets that get into us and attach to us. And so we don't have as great an immune response against it. We don't have immune response against all 5 antigens being expressed. And then it also gives the virus a way to attach to us and start to infect us. So that if we have a weakened immune system for whatever reason, maybe we exercised too hard that week, maybe we weren't eating right, maybe our diabetes is out of control, maybe we're sick for whatever other reason, we're taking steroids for some disorder that we have, whatever reason, maybe our immune system wasn't as active against the virus as it should have been, and hence we get sick. So you'd have to presume that there was some sort of population immune memory in order to not have 100% propagation. You're absolutely right.
Thanks. And in your experience now, since things have been slowly reopening and you had a lot of patients that weren't getting a lot of care during the last couple of months, have you seen a spike in any serious conditions, any illnesses that maybe could have been treated that weren't treated? And are there any other negative side effects, I guess, of what we've done?
Well, so what I'm seeing now is I'm seeing that the people's average blood sugars, my diabetics' average blood sugars have gone higher because people haven't been able to be as active. They haven't been out working. They haven't been going to the gym. They haven't been going out for walks because they're afraid. And so the average blood sugar test, that hemoglobin A1C, is now higher than it had been. People's blood pressures have been higher, and so we're working with people to get them back under control that way. And I think that if we can open up and be more active, not necessarily going to the gym, but for instance, my wife and I, we usually go to the gym 3 times a week together and go through a gym class. Well, that was shut down completely, and we started off going for walks each evening. And we thought, well, we'd go for a walk around the block, 20, 30 minutes or so, and kind of, wave at neighbors and such as we passed by. But that has expanded to where we're doing about 5 miles a night. And we're getting some good exercise that way. We have explored areas in Provo on foot that we hadn't driven through in 28 years. So we're getting very intimately acquainted with our whole city here. And those are the kind of things I would advise people, let's do. There's no risk of being out and about, with your loved one going for a nice walk. That is a low risk proposition. If you're going to go to a crowded area, you might want to take other precautions. Until compelled by certain retailers, I've not worn a mask in public. Again, I think that it's appropriate for me to be exposed to the SARS virus, so that my immune system can activate and promote a healthy immune response. So I haven't been eliminating myself from having an infection that way, or trying to put some other barrier in front of me. I do wash my hands regularly. As a doctor, I wash my hands about 10,000 times a day, it seems, until my fingers are falling off. I do wear gloves, with patients when I'm doing certain types of exams and such, but I have not been excessive in that. So if you are a person who's sick, if you've got a cough, if you've got a cold, if you've got the sniffles, if you've got a sore, scratchy throat, heavens, don't be afraid to wear a mask. That's an appropriate time. Limit your secretions to yourself, essentially. But for a healthy person, like you or I think it's probably inappropriate to wear a mask, but you do what you feel comfortable doing. And there are a lot of people who are scared right now, and mask shaming is not something we should be doing. We should be allowing people to feel as comfortable and protected as they want to feel. I've heard, one physician said that, it's this hand-to-face contact that promotes infection. Well, that's true for staph and strep and every other type of bacterial or viral infection. That's how you get viral conjunctivitis, is by touching door handles that were infected and whatever. And that's been around for thousands of years. And so he said jokingly, he said, well, why don't you just tape a piece of paper to your nose? That way you can't touch your mouth, and every time you put your hand to your face, you're touching paper, and that stops you from touching your face. It reminds you to not touch your face. Well, that would be effective, I think. But again, if you're sick, if you're coughing, if you're sneezing, if you're having a scratchy throat or a fever, please put on a mask or stay home. There's no need to deliberately go out and spread germs, whether it's common cold, influenza, COVID, or a strep throat. It doesn't matter. Keep your germs to yourself when applicable. But for the rest of us, I don't have any particular feeling like I need to be excessively cautious. But that's just my personal opinion. If you feel that you feel more comfortable putting on a mask and goggles and gloves and a hazmat suit to go shopping at the grocery store, that's fine. I'm not going to shame you anymore. Okay. A year ago, I would have thought you were strange. Okay. But I'm not going to shame you for doing what you feel comfortable doing. Okay. But neither would I expect you to point your finger at me and call the cops and tackle me and throw me in jail for walking around without a mask. But that's just my preference. That's where my personal responsibility takes hold. But if I'm sick, heavens, I ought to be putting on a mask for certain.
Sure. So I wanted to share something really quickly myself from the CDC website that I came across yesterday. Here, I think if you can see my screen here, it talks about spread of the virus, and here it says that the coronavirus spreads mainly from person to person and in close contact, droplets. But down here, it says the virus does not spread easily in other ways, and on that list is touching surfaces or objects. What are your thoughts on this? Is this new?
Like I said, viral conjunctivitis, a very common thing, especially in kids and such, we believe is hand to eye contact. So it makes good sense to me to not touch door handles and rub your eyes. I don't do that in my car. I don't handle the gasoline pump and get the dirty, dusty stuff on my hands and then lick my fingers. That just doesn't seem appropriate somehow. I wipe my hands down, wash my hands before I'm going to rub my eyes with whatever the contaminants are that are out there. I think that we've had lots of contact surface studies that have happened, and for instance, cardboard I believe was supposed to last up to 3 days. Well, that's can you extract viral DNA from the surface of the cardboard 3 days later? It wasn't a test of can you grow that virus to an infectious state from what's on the surface of that cardboard. So is it clinically significant, or can it be extracted? Those are two different questions. I don't know for certain. I will take the CDC's word for it that it's less likely to be contaminated or contracted by touching a door handle or something. But I'm not going to rub my hand down a hand railing and wipe my eye with it regardless. I wouldn't do that last year or the year before.
You might get something else and not COVID, right?
Yeah, I'll get some staph or strep or something. I don't know what's on there, like bird dew or something. I don't know.
I just feels like they post things like this, and I think that it does people a disservice, and by making them feel like it's okay to have these other behaviors, as if COVID-19 is the only thing that exists, or coronavirus is the only thing that exists that could harm us. And so I think it's wrong what they're.
So I will share with you, quote, the doctor's secret. Okay, how do I avoid respiratory infections? So clinical infections. When I'm seeing patients who have sinus infections and bronchitis and pneumonia on a daily basis through the cold and flu season, how do I not get sick all the time? Well, one thing we have to understand is that most respiratory infectious agents, viruses or bacteria, are what are called microaerophilic, which means they only like a little bit of oxygen. So they don't grow in well-oxygenated environments. If you inhale, say a strep bacterium, and it goes up into your sinuses, and you let it sit there, then your initial immune response causes mucus secretion, which congests your sinuses. If you go outside on a cold day, no infection present, you might get congested. Once you get congested and you block off oxygen to a portion of your sinuses or your inner ear, your middle ear or so, then the bacteria, the viruses that are already present that you've been breathing in get to stay, and they set up house and they start to grow. And so you have this opportunistic growth of bacteria and or viruses. So what we know about SARS virus, for instance, is that people can carry the SARS virus in their upper respiratory tract, their sinuses and such, for 2 to 5 days before it causes symptoms. Well, that's what I'm talking about. See, we want to decongest. We want to have the virus particles moving outward so that they don't take hold. They don't have a chance to opportunistically grow. So, what do we do? Stay hydrated. That's a big thing. Through the winter months, which tend to be drier here in Utah, the humidity drops because of the cold, and everybody turns on their furnaces and we dry out our sinuses, and so we don't have mucus flow, which then pulls out and pushes out all of the contaminants, bacteria, viruses, and allergens. Also, there are products such as guaifenesin, which is found in Mucus Relief and Mucinex, which can enhance the watery nature of mucus secretions. So yeah, you might be blowing your nose several times throughout the day to get rid of those extra secretions, but in so doing, you're also not allowing any of the contaminants to stay there. It helps with allergies. It helps with cold and flu season to not get the infections. Now, am I being exposed to those antigens? Yeah. Is my body mounting an immune response? Yeah, a little bit. Am I getting an infection? No. And I think that's kind of an important thing. If you walk around and you're congested all the time, you're likely going to get more infections than someone who is not congested. And so that's kind of like the doctor's secret that way. Wash your hands, don't touch your face, and decongest.
The opportunity to hear from you, to hopefully share this with more people, where people can start to feel more normal, because they should feel more normal, and not be afraid to go out and be misinterpreting a lot of the news that's out there and the numbers that are panic causing. And so I think that's really important, and hopefully we can do that. With church, like here in Utah, we were announced that people can start to go back to church again, and even the predominant religion in Utah, the Church of Jesus Christ of Latter-day Saints, they're talking about moving back to church. And are we going to see spikes and as a result of this? And should we be afraid of going to church? What?
Well, will we see spikes? Will we see more people test positive or have COVID-19 infections? And I think the answer is certainly. But what was the point of flattening the curve? The point of flattening the curve was to not overwhelm our healthcare system. This virus, this specific SARS-CoV-2 virus, has to work its way through our population. We have to get to a point where we have 50 to 60% of the population immune to it so that we don't have epidemic numbers of people getting sick. We have flattened the curve. It's squashed. And it literally is squashed. You know, they were saying 2.5 million, then 1.5 million, then 240,000, then 150,000. And then they said, well, maybe 60,000 at the most. And here we are at 30,000. We're now going into summertime. And as we get into summertime, like every other coronavirus and rhinovirus out there, this will dissipate. But we can expect that it will be back come cold and flu season, which is officially October 10th to April 10th. So we expect it will rear its ugly head. But how do we not have epidemic proportions of numbers of people in the hospital? How do we not overwhelm hospital systems? Well, number one, we never came close to overwhelming hospital systems. I mean, that just never took place. A perfect example is California, which has, in the state of California, there's 60 million people. They've had 85,000 total cases positive. They've never had more than 5,000 people in the hospital at a time with COVID. Well, how many hospital beds are in California with 60 million people? They actually have 73,000 hospital beds, and they run an average occupancy of 55.6%. So that means about 30 to 40,000 hospital beds were empty this whole epidemic. Okay, we were never at risk of overwhelming our hospital system. They've never had more than 1,500 people in the ICU at any given point in time during this whole epidemic. How many ICU beds are there in California? Well, there's over 7,000 ICU beds in California. How many ventilators are in California? There are almost 30,000 ventilators in California. How many people have been on ventilators at a time? Less than 1,000. We've never been at risk of overwhelming our ventilators, our ICU beds, or our hospitals through this whole epidemic. There's only one time, and that was in this 2-week period in New York, when there were a few downtown New York hospitals that became overwhelmed with patients. The interesting thing when you look at the demographic and the outline of the hospitals in New York City, within about a 5-mile radius, there were some 800 hospital beds sitting empty, while these few downtown New York hospitals were full. And I don't understand that dynamic. We know that, for instance, if one of the local hospitals here was experiencing a rush on their emergency rooms, let's say a building caught on fire and they had 25 people coming in, they would go on, quote, diversion. So the ambulances would stop coming to that hospital. They would go to the next nearest hospital and then the next nearest hospital to handle all of the patients from that tragedy or whatever. But my understanding is that these hospitals never went on diversion. They kept accepting patients. They kept converting their general medical beds into ICU status beds to handle patients coming in. Yes, there was a surge in New York City. There certainly was. And that's why their hospitalization death rate sat at 21%, whereas the rest of the nation, including their 21%, remember New York is about 1/3 of the deaths, including their 21%, we're only running 12-13% death rate for hospitalizations across the country. If we excluded New York City, we might be as low as like 8 or 9%. So New York City is its own little spike, and it sounds like, you know, in retrospect, 6 months, 12 months from now, we might find out what the real problem was, what the root cause of that, you know, that problem was, that mistake that happened that caused so many excess deaths. But that was abnormal. It was atypical. It's not what's happening in the other 49 states. And it hasn't happened anywhere else. Here in Utah, according to our governor, we haven't had more than 5% of ICU, of hospitalized beds taken up by COVID patients at any given time. We've never had more than 20% of our ICU patients be COVID patients. We're sitting at well over 70% empty in Utah right now, hospitalization and ICU. So we don't have a surge problem. And you can look at the CDC website. They have averaged in the yearly data right now for hospitalization use. And this time of year, we should be running about 60% full. And right now, we're running like 25 to 30% full across the state. And that's principally because all of the elective things have been canceled. So people who needed knee replacements, hip replacements, shoulder replacements, people who needed pacemakers put in, people who needed angiograms and venous treatments and such couldn't go into the hospital. I couldn't get people to go in and just to get an ultrasound of their gallbladder. Okay, we had to go out to other imaging centers because they couldn't get into the hospital to have that imaging done. CT scans, MRIs not being done in the hospitals. There have been thousands and thousands of hospital employees that have been furloughed. Think of all of the surgical staff that should have been there doing knees and hips and spines. They've all been sent home. And that's an economic hardship that we can see because COVID has not overwhelmed anywhere except New York. And that was actually unnecessary. But again, retrospectively, you know, hindsight's 2020. We can see that as we look back at the data. But this has been an ongoing, keep looking at the data, keep interpreting the data to the best of our understanding. And you know, I can see as the governor, it could go both ways. If you'd gone supreme lockdown, like Michigan or something, and nothing ever happened, then you're a bad guy. If you had been completely open and something bad had happened, well, then you're a bad guy. You know, we've been kind of in between. Thankfully, we've not been a complete lockdown like many states. We've not been on forced mandatory, which I think is unreasonable. But we've been lucky here in Utah to be left to our own recognizance, so to speak, and that's good. But you know, I've got a daughter who lives in Vancouver, Washington, and they've been on forced stay-at-home orders now for going on 2 months, and she's got 5 kids. Imagine if you're forced to stay at home with 5 kids in your house. You can't go to the park. You can't go play soccer. You know, you can't do anything. You're stuck. That's crazy. I'm glad we're in Utah. I love Utah.
This was really great, Dr. Ogden. I appreciate you taking the time to do this. And the name of your practice here is
it's Achieve Health. We're in Orem, but again, you know, one thing I do want to stress, and that's that you know, people have their individual agency, and there are many of us who are going to feel like we want to be dressed in hazmat suits, and that's fine. There are many of us who feel like we should just go completely open air, and that's their choice. You know, some people are speaking against businesses that are requiring masks to enter. Well, that's their business choice. You know, they have that agency as a free enterprise business to request that. And there are those businesses that say, no, come on in, no masks required. That's fine. You know, I'm not gonna stand and shame either of those two sides, because those are individual responsibility choices. I've made my choices, and I'm willing to live by the effects of my choices. If I have a horrible outcome with the SARS virus when I encounter it, that's my choice. You know, no one can say, "See, I told you so," because I'm taking that risk as an individual with complete understanding. But I'm not going to look down upon somebody who wants to wear a mask. I'm not going to look down upon people who don't want to wear a mask. That's their choice.
It is their choice. And that there might be one last thing. There seems to be a lot of controversy over asymptomatic people being contagious or spreading it or not spreading it. I mean, what does your experience tell you?
Well,
What
I mean,
does logic tell you?
so if you're not symptomatic, if you're not coughing, if you're not sneezing, if you're not spewing your virus-laden particles into the air, are you contagious? They may be able to
They're saying yes. I don't know.
Well, they're saying that we can stick a swab in your nose and pull out virus particles. But if you're not coughing and sneezing those particles out into the open air, those particles are sitting in your nose. Just like I talked about, you know, I get exposed to things, but if I don't let it sit there and grow, it doesn't become an infection. So you might be able to swab my nasal passages and come out with virus DNA, but it doesn't mean that I am a contagion. I'm not spreading that to other people unless I'm coughing and having the immune response to it. You know, if I'm not coughing, I'm not spreading. If I'm blowing my nose into my hand, then I'm gross. Okay, and you shouldn't shake hands with me regardless. But if I'm generally hygienically normal, then there's not a fear in that 2 to 5 days before the virus becomes an infection.
How does that explain we've heard of a couple of naval ships that had outbreaks without symptomatic people on the ship. Is that?
Well, what do you call? So the question is, what do you mean by outbreak? Did they test positive? Sure. It's not an outbreak until someone's sick. And so once you're sick, you have symptoms. So in those 2 to 5 days before I have symptoms, I'm not spreading the disease around unless I'm not hygienically sanitary. If I'm coughing into my hand and shaking hands with people, that's not hygienic. Okay, you wouldn't do that on a good day. If you see somebody sneeze into their hand, you don't go up and shake their hand. You'd go, ew, no thanks, I'll pass. But those are symptoms. A cough, a sneeze, those are symptoms. And so if you're having those symptoms, you're contagious. If you're not having symptoms, then you're not. So if I walk into, let's say I walk into a room with a patient who's actively coughing and they're spewing virus particles, and I inhale those virus particles and I wash my hands and wash my face and I go out the door and I walk over to my wife and give her a big hug, did I just pass on the virus to her? No, the virus is in my sinus cavities for the moment, and until it grows in numbers to become an infection and I start coughing it outward, my normal breathing is not going to spread the virus. I have to have a symptom that spews the virus out in moisture particles.
Yeah, it makes sense logically. It just doesn't, you just hear so much panic in the media and stuff, and that's again, that's part of the problem. Now, when I think that there's some pretty good statistics out of like Japan where their case counts are apparently extremely low, like unusually low, and they're attributing that to that the culture wears face masks kind of as a common practice. Is that the explanation to that, or what do you think?
So it makes sense if you've got a room full of 100 people, and 2 of those people are having symptoms, and they haven't admitted it. They're walking around going, snorting their nose and wiping their nose, and you know, those two people are having symptoms and can spread the disease. Now, if all 100 of those people in that room are wearing face masks, then those two people will not have the opportunity to spread their droplets. So that makes perfect sense.
So then someone would say, well, that should be what we do. Why wouldn't we just, why shouldn't everybody be forced to do that if that's the effective way to do it?
Again, that was like I said, my personal feeling is I think I need to be exposed to the world's viruses and bacteria in general so that my immune system stays strong. But that's my personal feeling. You know,
I agree.
I don't believe personally that I would want to wear a face mask to stay protected. I wouldn't want to live in a bubble. I wouldn't want to live in a safe room in a mansion somewhere for the rest of my life. I want to enjoy this world.
It's a freedom choice. It's the right thing too. I want to see when you're smiling and when you're frowning, and I can't see that if you've got your face mask on. So
that's very true. That's
well,
very
on
true.
On that note, I'm going to go ahead and say thank you again. I'm going to end the recording right now.
All right, George. Thanks.